In this plenary, we're talking about hepatitis C, which many of us know has got a lot of attention, both from a policy perspective and also from availability of medications and treatment options that are there. And we're talking about elimination because of all the progress that has been there. Margaret was talking about the number of, globally, number of people that we have been able to reach and we have been able to treat. And I would also like to emphasize that we have not controlled this infection. In the past approximately 12 months, we treated around 1 million people, and there were 1.7 million new cases. So in spite of new drugs, in spite of availability of infrastructure, development of infrastructure, we still have not done good enough. I'm also happy to tell you I have no conflict of interest to declare on the topic that I'm going to talk about. Just to give you an outline, as to where, what I'm going to talk to you about. I'm going to talk to you about policy, which will help us improving access and to achieve the elimination targets that we talk about globally. If we are to achieve, if the policies are there helping us, what needs to happen to improve access? What is it that has to happen for the patients to have those medications in their hands to be able to take it to achieve a cure? I'm going to talk to you about a little bit more, and I'm going to talk specifically on the Indian licensed medication, which we also known as the direct-acting antivirals, or DAAs in short. Where are the regulatory status? Where is that? We heard about licenses that has been given to the Indian generics, but where are these medications that has been provided licenses for? What is the pricing? I'm going to go a bit more detailed into this, and also about the programs that are in existence in our region, in some of the countries that are there with the limited infrastructure and manpower and resources that we have. Where do we stand? In case if the countries are not there having a national program, then what are the alternate approaches that you have as a physician who is trying to manage a patient, or as a patient who is trying to get a cure? And at the end, it's about a summary slide on conclusion. So policy, where do we stand? We know Global Fund has played a very, very important role in terms of grounding the HIV work that we have in low and middle income countries. And most recently, the expert review panel of the Global Fund has approved 2 of Indian generic manufacturers, the sofosbuvir, which is produced by 2 of the Indian sofosbuvir, 2 of the Indian licensed manufacturer. This means that these products will be available soon after a WHO pre-qualification process, or this also gives a green signal to country programs or other programs, public health programs, who would want to procure this medication. Another one is WHO. In low and middle income countries, definitely without the WHO guidelines, nothing really moves much. And we have seen that as in our HIV programming, how much the WHO guidance have actually helped in shaping the national programs. WHO in our region, which is the West, we have two regional offices in our region, which is, one is the Western Pacific Regional Office, and they have approved their regional action plan in October of 2014-15, following which a number of countries have started developing their national programs. In May 2016, the Global Health Sector Strategy on Viral Hepatitis was finalized and approved. Very recently, in April, the Southeast Asia Regional Office has also approved the regional plan, and at the moment, what is ongoing is the pre-qualification of the sofosbuvir, and the guidelines from WHO on hepatitis C is being updated at this point and likely to be released by November. We have all these policies that is supposed to help us as a policymaker, as a patient, as a physician. But what needs to happen to get access, to improve access for the patients? Approximately only 5% of the people have been diagnosed, and we need to find those people. That gap of 95% is something that we have to reach and find if we are to reach the elimination target by 2030. And WHO recently has first approved the first rapid diagnostic test for hepatitis C antibody. And that's a very positive step in terms of making sure that large coverage of screening patients do happen. We have to register these drugs. In many countries, and I'll show this where we are in terms of the availability and registration of this drug, but we have to get this medications as fast as possible. If the medications are there, we have to make sure that these drugs are affordable for patients and for national programs to absorb and be able to provide to its citizens. Egypt and India are examples of major price reductions that has happened. And as Margaret had mentioned, Egypt treated around 850,000 people. And that was starting from a period of October 2014 until now. If they have treated 850,000 people, why not the rest of the countries? One of the primary factors there is the cost of the medication. Starting from peg interferon days when we were paying $350 to $400 a vial of pegylated interferon, Egypt was paying $40. And right now, they pay around $84 for a generic version of sofosbuvir and daclatasphere. That is where they are, and that's how they could cover that many number of people. Of course, they also use innovator drugs. We also have to expand the number of physicians that are available. And I'm sure you all here, quite a lot of people here, actually has been taking care of a lot of people who have HIV and also hepatitis C co-infection. If we take examples of few countries here, for example, Indonesia, and there might be some people from Indonesia in this room. Indonesia has 157 hepatologists who are allowed to prescribe and treat people with hepatitis C. And they have approximately 1.2 million to 1.5 million hepatitis C cases, leave alone 18 million hepatitis B cases that they have to take care also. How do you think 157 people are going to manage a pool of 1.5 million viremic cases only on hepatitis C? So we have to expand, we have to build, we have to build the skills of ID physicians and also general practitioners to be able to prescribe and treat and monitor the patients who needs their care and who a lot of you have been taking care of for the last 15, 20 years and managing their HIV very, very well. And that seems to be a big challenge that we have mostly specialists that are being that are allowed. With due specialists, with due respect to all the specialists in this room, we need to expand the coverage and we need to allow GPs and ID physicians and other people from other fields to be able to treat. In terms of where the DAAs are in the region, we know quite a lot of people have used Sovaldi. A lot of countries have started using Sovaldi. And I'm sure some of you here have started using the Sovaldi, which is the innovative version of sofosbuvir. We also know about Harvoni, which is ledipasvir and sofosbuvir co-formulation. And also heard about Daclinza, and some of you must have used it, which is basically daclatasphere. We also have seen, and some of you have used the generic formulations of sofosbuvir. And also generic formulations of ledipasvir and sofosbuvir and daclatasphere. I'm just showing a few examples which I could gather, and this is not to specify any companies or any products here, but just to show that there are generic formulations and generic versions of this DAAs available. In terms of this is a slide which Margaret just showed. Where are we in terms of the DAAs in the region? Bangladesh is a least developed country, so they don't have to provide any patent on medication at this point. So you have all the versions except one which is red crossed out, developed by Bangladeshi generic companies. In India, because of a license that has been provided by the innovator companies, the Indians, they have versions of generic DAAs. In Indonesia, they have both innovator and also generic version of sofosbuvir and semipravir at this point. And what I would like you to note is something which is called as a special assistance scheme, which is allowed by the national FDA to import drugs to be for use by hospitals and clinicians prior to a registration, a formal registration of a drug. In Myanmar, there is the generic versions of the AAs that are available. In Nepal also, these are the Indian suppliers that have gone in and registered their medications. And Thailand, we have all the innovative version of production of its, to my information, Harvoni is still to be marketed, although the approval for registration has been there from our Thai FDA. In the Wipro region, we have Cambodia, which have got the generic version, and they were one of the first countries in the Southeast Asia region, not as per WHO classification, but as in the Southeast Asian countries to get generic Epclusa, which is Velpatasvir and Sofosbuvir co-formulation. In Malaysia, we have Sofosbuvir and APACC, which is the AB combination. And Vietnam also allows, besides Philippines, Vietnam also allows the same system, which is importation of medication prior to a formal approval. In Vietnam, they call it as a special import quota. So we have heard about the licenses that the innovator companies have given either bilaterally or through the Medicines Patent Pool. The first branded version of Sofosbuvir was approved in December 2013. And the licenses were given to the Indian companies in September 2014, which was later expanded. The license was for the Gilead products were for 101 countries. And as of now, Sovaldi has been able to be registered. The originator company has been able to be registered in 26 countries. These are in developing countries, excluding the developed countries like Europe and the US. The generic Sofosbuvir, I'll come into details at later slides as to where these are exactly. The generic Indian companies have been able to register this product in 23 countries. Harvoni got FDA approval in 2014 of October, and the originator company has been able to register in 18 countries, which are in developing settings, and the generic Indian suppliers have been able to supply in 12 countries. Daclatasvir, we have no information from the originator, but the Indian generic suppliers have been able to register it in 9 countries, and Epclusa in 3 countries, a generic version of Velpatasvir and Sofosbuvir until up to 3 countries. Now, let's look at where we are in terms of this drug. This is solely from the Indian companies. The Indian suppliers have been able to register. So in Asia Pacific, we have 8 countries who have been able to register these drugs. There are 3 which are pending. And Sofosbuvir is not the only drug. I mean, it's suboptimal, as many of you know. It's suboptimal to prescribe only Sofosbuvir and ribavirin-based therapy to a patient. So you need more drugs beyond. If you look at Africa, there are 9 countries. And the African countries got registration dossier much later than the Asian countries. Some of our countries and our own FDAs have been really taking a lot of time to make sure that these drugs are of a short quality and meets the criteria that is needed for the country. But the African countries have trusted a lot of data, and they have really progressed pretty fast. One of the example in our region, which is a little bit off, is Mongolia, who gave very fast track approval to this medication. They got like 2 or 3 days registration approval. They provided approval within 2 or 3 days to the innovator, and very quickly to the generic suppliers too. But some of our countries have taken quite a long time to get this. Ledipasvir and Sofosbuvir, which is good for a lot of countries in our region, like Vietnam, say for example, like Indonesia, and we have been able to get this in only 4 countries simultaneously the same number of countries in Africa too. And so 2 of the countries are also working on this. 98% of Vietnamese patients are going to be taken care by this drug because because of a type of genotype they have in their country. In terms of Daclatasvir, we have 4 countries that has been able to approve this medication, and we have 2 from Africa that has been able to approve this medication. Velpatasvir and Sofosbuvir, We have 3 countries. Cambodia has done great in terms of proving this drug pretty quickly. And we have Myanmar, which is looking into it. The point that I'm sharing this information is sofosbuvir, number 1, is suboptimal, as we know, to be given alone, along with ribavirin. And a lot of patients need this medication. The longer that our FDA takes to get this registrations, the more time you are taking to be able to prescribe for your patients, and the more time the patients are actually needing to get this medication. Some of the patients have really advanced fibrosis stages, and they would need this treatment as early as possible. So when you go into the meetings with MOH or the FDAs in your respective countries, please do note and please do cite about people co-infected with hepatitis C and the need for these drugs and how we can get this as fast, and also explore the possibilities of something like a special import quota or a special assistance scheme that Vietnam or Indonesia has. This is the price, and we have been tracking. This is in India from the generic suppliers, and we have been tracking this for quite some time now. And sofosbuvir now, which is famous for in the U.S. For the $1,000 a pill price, we can get sofosbuvir for $60 a bottle in the private market. Sofosbuvir and ledipasvir, we can get it for around $83. And the daclizumab for approximately $23 a bottle, which is basically per month. And the generic Epclusa, valprotasvir and sofosbuvir, which came out a month ago, you can get it approximately for $192 a bottle. If we look at this is a price from a state of Punjab in India, which I will describe later in one of my slides. India does not have a national program, but they have state-led programs, which Margaret was talking about. So in the government supply, against $60 for sofosbuvir, the private market, you can get it for $24. And for sofosbuvir ledipasvir, against $84 in the private market, you can get it for $61, which is approximately, it can vary a little bit depending on the exchange rate that you calculate. And a bottle of daclizumab is approximately $12 a bottle. So you're looking at basically $249 to treat a patient of yours, non-cirrhotic, 12 weeks, soft ledipasvir for $249, and valprotasvir for $576 for a 12 weeks treatment course. If you're talking about a government program and what the Indian government has purchased it, you're talking about a soft-lead combination of $183 and a soft and DAC combination for a non-cirrhotic patient at $108. And I'm sure quite a few countries will be able to absorb this cost if we are to start a national program. Now, this is not the same in many of the countries in the region. So in India, the Indian generic suppliers have supplied this medication and selling it quite low cost. But if you take other considerations, other countries nearby, which may have even lower GDP than India, you're talking about Vietnam, the same thing that cost $83 soft ledipasvir, sofosbuvir in Vietnam, they're selling it $808. In Cambodia, it's $705. In Myanmar, it's $300. In Indonesia, it's $469. If you meet these companies, if you meet the people that are there, if you meet with your MOH, please ask them, why is this price variation? Is this because of a tax that our country levies on medicine? Or why is it that there is such a big difference in terms of pricing, that you're selling this medication in India at this cost, and why are you selling this medication in our countries at this much of a cost? They have to justify that. There has to be a reason as to why they're selling this. Either it's profits, or either there is something that is related to tax that is there. And you need to push to make sure that this people who are representing these companies comes in and then gives you a valid reason as to why these are so expensive. These are some of the countries which are within the license. But let's add on other licenses. So if you look at the US per bottle column, the vertical column, our pricing range is within $900 still, even if it's high. But the moment you add on countries which are outside, our range comes up to $14,000. And I have added here 3 countries which are outside of a license, which are basically Thailand, Malaysia, and I've also added Hong Kong, where this conference is being held. So the same medication which costs $80 in India is $2,000 from the innovator company in Thailand. And there is not a lot of patients in Thailand who can actually pay $2,000 a month, and that's around 70,000 baht. And this is way, way more than what a patient can actually pay. In Malaysia, it's around 10,000, and this is outside of the hospital markup. So this is a price which the company has supplied. So if you're buying from a hospital, either from a government hospital or from a private hospital, the price will be different, and this will be more than this. In Hong Kong, it's around 12,800. It's around 12,835. I kept it around at 12,800 just to have a round figure. This is approximately 100,000 Hong Kong dollars a month. I don't know how much, as per the income in terms of families and individuals, I don't know how feasible it is to pay for a patient $100,000 Hong Kong dollars a month here to get cured from hepatitis C and also take care of family and children. So where are we in terms of the national treatment program? So Thailand has been one of the countries in our region which has led the hepatitis C treatment program as a national treatment program. It is provided under the National Universal Healthcare Scheme, which we also call as UHC, and started from 2012, and it's provided to all Thai citizens above the age of 18. We still use pegylated interferon and ribavirin-based regimen, and there has been kind of a negotiation that has been going on with the companies that can provide this medicine as to the pricing of how much they can provide with the DAAs. The coverage criteria, we cover from genotype 1, 2, 3, and 6, and HIV co-infection. If the person is on antiretroviral for HIV, then the CD4 has to be more than, if not on ART, then it has to be more than 350. And if on ART, if on ART, then the CD4 has to be more than 350, and if not on antiretroviral, then it has to be 500. The person has to have fibrosis staging by FibroScan, and it has to be F2 or above. So far, the Thai UHC has provided, through 2016, 4,503 patients. Beyond this, India is again an example, and health is a state subject there. And Punjab and Haryana, these are some of the states which has taken the lead in terms of providing treatment to its citizens. And approximately in the state of Punjab, there are around 600,000 viremic cases in the state, and they initiated a program in June of 2016 and uses all oral antiretroviral drugs. And the coverage criteria for them is all fibrosis stages and all genotypes. And if non-serotic, they do a 12 weeks daclofenavir and sofosbuvir. And if serotic, they do a genotyping to the patient. And based on the genotype, either soflet or sofosbuvir and daclofenavir is given. And so far, as on April 2017, they have treated 25,217 people. So this is an example from a state of Punjab who is getting $108 for a soft daclofenavir regimen. Beyond this, we also have Mongolia, which I cited, and have provided a fast-track registration to the medication. And the National Health Insurance covers approximately 30 to 62% of the medicine of the cost, which are all oral DAAs. And 30 to 62%, this variation depends on the brand that you're using. They have 5 brands altogether that are registered in the country. Each has its own pricing. So if you are purchasing the least cost, you're getting the highest reimbursement. If you're purchasing the highest cost, you're getting the least 30% reimbursement. That's how it works out in between that 30 to 68%. The rapid national, the process of getting these medications is actually the driving force in terms of the price competition and also making the government do the reimbursements. In Indonesia, there's a national program, as Margaret cited, of 6,000 patients, but they use sofosbuvir and simipravir and ribavirin. And as you know, simipravir is contraindicated with all the antiretrovirals that we use in our setting, including the PIs that we use. So for co-infected patients in Indonesia and on antiretroviral, this is not going to be an option. And also, it's currently limited to Jakarta. They're having some tie-ups with certain international NGOs as to how other drugs like daclataxivir can be provided to add on to that sofosbuvir, but that has not materialized so far. In Vietnam, there's a national coverage scheme where National Health Insurance provides 30% of the cost, and that cost is again on PEG interferon. If you do not have this national treatment programs, what are your options? As a physician, how do you want to get this? As a patient, how do you want to get this? At the hospital level, that is what I talked about, a special import license. Please check if that is possible in case if your countries do not have access to these medications. This is known by different names, so what you can ask is there a way that we can import a medicine for use of our patients before the medicine is registered in a country? In Vietnam, that's called a special import quota. That's what I mentioned. In Indonesia, that's called a special assistance scheme. Please check that with your hospitals if you would like to prescribe and get this for your patients. At the patient level, there is a named patient import where certain countries allows patients to import, and the industry sometimes that also calls this as a compassionate use program, and patients can get it for personal use medications which are unregistered in the country. There are buyers clubs which are functioning in many parts of the world, that is also another option, provided you check the source and the quality of the medication. And you can also go to India and get this from large pharmacies which stocks these medications. In conclusion, we have regional policy developments which support expansion of treatment programs. We have international resolutions starting from 2010, which are enabling our governments to act on this, which we should, as civil society, as physicians and infectious disease societies, should follow through. We have national health programs, but it's pretty slow. We have leadership which needs to take care of. We require fast-track registration. We need to have better price negotiations, and we have to play a role in terms of what we can do as GPs or ID physicians when we possibly meet with people either from industry or from the government. We have these drugs which are coming up, but it's fairly limited, as you have seen. We need to broaden the number of physicians that we have who can actually treat this infection, and moreover, we also need affordable price of these medications so that we can ask our governments, and our governments can actually start prescribing these medications and as part of our national health programs. Thank you very much, and I'll be happy to take questions later.